Good day. My name is Kailit Phua. I'm a retired professor of public health. I used to work at Monash University School of Medicine and Health Sciences in Malaysia. Some biographical details. The title of today's lecture is Access to Healthcare, and these are the lecture objectives. First one, what's the difference between availability versus accessibility? And then the different dimensions of access to healthcare, travel time and distance, financial access, cultural compatibility, informational or knowledge of healthcare resources in the community, and then we move on to equity, horizontal equity versus vertical equity, and then equity in terms of overall access, in terms of utilization or use of healthcare resources, outcome, results after using healthcare resources, how it affects our health and our well-being, equity in terms of financing, equity in terms of the geographical distribution of human and physical resources. Okay, this is the difference between availability versus accessibility. Availability simply means health resources such as clinics, hospitals, nursing homes, health providers, are they located nearby? Accessibility means ordinary people, ordinary citizens, able to gain access to or make actual use of available health resources. Okay, first dimension of access, travel time or distance to seek care. So, is the distance to travel to seek care reasonable or not? All right. Do people have to travel a long distance, many kilometers or miles, in order to see the doctor, in order to go to the hospital? In a big city, are there severe traffic jams which increase travel time by significant amounts? And at the healthcare facility itself, especially at public facilities, all right, public facilities, are there long lines of waiting patients? So not only a matter of getting to the health facility, but how long do you have to wait before you're actually seen by a doctor or other health provider? Are appointment or waiting times reasonable? That is, if you feel you have a health problem and you make an appointment, do you have to wait a long time, right? Many days, maybe even weeks or even months before you actually get to see the healthcare provider face to face. Is the geographical terrain associated with land travel difficult? For example, are you located in the countryside and it's difficult to get to the city where healthcare resources are more likely to be located, right? Do you have to travel to mountainous terrain, right? Do you have to, or other physical barriers to easy land travel? Now, if land travel is difficult, is air travel feasible, right? So including medevac or medical evacuation. If you have a serious health problem, can you be flown from an isolated area to the health center or hospital itself to be treated? Okay. If the patient cannot travel to the health facility, can healthcare providers travel to come and treat you. For example, flying doctor services available. So for example, in Australia, they have a flying doctor system, and in eastern part of Malaysia, on the island of Borneo, states of Sarawak and Sabah, you actually have healthcare providers traveling by helicopter or light aircraft to isolated communities to treat patients. What about financial access, right? Primary care, GP level care, hospital care, nursing home care, are these affordable to patients with health problems? Do people have to go into debt, right? Borrow money, or even become bankrupt because of unaffordable care or high drug prices? So care can be expensive if people are hospitalized for long periods of time, or they're being treated by you taking proprietary or branded drugs under patent protection, but which are priced very high by pharmaceutical drug companies. Do people have to actually forego care because of lack of money until the health condition gets life-threatening? Another dimension of access is cultural compatibility. Do people fail to seek care because of cultural clashes, cultural mismatches? For example, psychiatric services. Do people prefer seeking care from alternative providers because they don't have faith in psychiatric services or in psychiatrists? For example, would they prefer to go to shamans, right, for treatment, or do they go to spirit mediums in temples, right, if they have any psychological or psychiatric problems? Now, does the gender of the patient or the gender of the doctor affect care seeking? In certain societies, women may be uncomfortable about being treated or seen by male doctors, right? So this would be a barrier because of gender. So the female patients actually prefer or seek care from female doctors. Another dimension of access is information or knowledge. Do people with lower access to information, such as being able to go online using the internet, etc., lack knowledge about what healthcare resources are available in the community? Now, these resources would include services provided by non-governmental organizations, NGOs, or PVOs, private voluntary organizations. So for example, if a relative has a serious chronic or degenerative condition, health condition such as Parkinson's disease or Alzheimer's disease, are they available or are they aware of what's available in the community, so that they can get their proper treatment for their sick relative? Now, equity. Equity simply means fair and reasonable treatment between individuals and across social groups. So, for example, if people are from different ethnic groups, right? Some people are rich, some people are poor, some are men, some are women, some are lowly educated, and some are highly educated. Is there reasonable access for people across these social groups? Equity, you can look at it in terms of horizontal equity, namely, people with equal needs are treated equally in terms of treatment of disease X or health condition Y, and so on. Vertical equity means people with greater health needs are provided with more health services. There's some philosophical or moral issues here. Some argue, especially in countries where the prevailing opinion is that healthcare it's a commodity, and access should be based on ability to pay. There are some people who, because of unhealthy lifestyles, they smoke more or they drink heavily, right, and poor diets, and then they fall sick with serious illnesses or with conditions such as diabetes, coronary heart disease, and so on, right? So one argument is because these people have unhealthy lifestyles, so why should the taxpayer pay for their higher medical bills? Other aspects of equity, you can have equity in terms of access, that is ability to make use of healthcare resources. Equity in utilization, meaning actual usage of services. So the first one is equity in potential use. The second one is equity in actual use. Then you have equity in health outcomes in terms of morbidity rates or illness rates, mortality rates, death rates, life expectancy, how long on the average a person is expected to live. For example, life expectancy at birth, life expectancy at age 60, and so on. Then it's also equity in financing, who pays, right? So who pays for financing healthcare through maybe for paying taxes to the government, right? Then there's equity in distribution of health resources, meaning geographical distribution. Are there a disproportionate number of doctors and health facilities in urban hospitals versus rural hospitals, which is usually the case in most countries in the world, right? Is there specialist doctors tend to be concentrated in richer areas of the country or more urbanized areas of the country compared to poorer areas of the countries or less urbanized areas of the countries, etc. Okay, this is the end of the lecture. Thank you for listening.